Good evening to all my dear students. So this discussion session will be a very short discussion session of the MCQs that were asked in the Monday midday quiz. So Parkinson's disease was the topic for today's exam. So for the viewers who are joining in new, well, Monday midday series is a series of topic-wise MCQ exams open to all in the DocTutorials app. And this happens 9 p.m. on every Monday, which is then followed by a discussion. Again, as I said, a very short discussion. So let's go to the 10 MCQs and discuss them. I hope the exam was relatively easy this time. And I think at least 7 questions out of the 10 were relatively very easy. Okay, so let's start. Number 1, not a cardinal motor feature of Parkinson's disease. You have got to read the question carefully here. I'm asking about cardinal motor features. Okay, cardinal motor features. So the point is that all the options which are listed here, options A, B, C, and D, all of the following or all these are actually motor symptoms of Parkinson's disease. But the question, the key word is cardinal motor features. So even in my lectures in the DocTutorials app, I have shown you this very important table on the clinical features of Parkinson's disease. Now, can you tell me in the chat box what are the cardinal motor features? Number 1, bradykinesia. Number 2, rest, tremor. Number 3, rigidity. And number 4, postural instability. These are the cardinal motor features. Well, there are certain other motor features also associated with Parkinson's disease, like micrographia, masked facies, or hypomimia. You call it hypomimic facies. So reduced eye blinking, drooling, soft voice, dysphagia, freezing. So these are also other motor features. So altogether, these are the motor features, but please understand bradykinesia, rest tremor, rigidity, postural instability, they are called as cardinal motor features, and that is what is asked in this question. And remember, there are certain other known motor features also associated with Parkinson's disease. So if you look at the options, bradykinesia, yes, it is a cardinal motor feature, so I can eliminate it. Rigidity is a cardinal motor feature. Postural instability is a cardinal motor feature. Hence, the answer is option B, hypomimic facies. Clear? Okay. Let's go to the next question. Question number 2. Which of the following may precede the onset of classic motor features of Parkinson's disease? So you've got to understand the evolution of symptoms in Parkinson's disease. See, many a times patients are diagnosed with Parkinson's disease once they present to the clinician with slowness while walking, tremor, all those features which you already know about. But please understand that much before the evolution of these classic features of Parkinson's disease, neurodegeneration happens. See, suppose if a patient develops features of Parkinson's disease by the time he is, say, 55 years of age. But do you know that certain other non-specific features like anosmia, smell problems, constipation, REM sleep behavior disorders, all these can develop, say, at around 40 years or 45 years. But why is the disease not diagnosed then? Because these are relatively non-specific features. Tell me, does any clinician diagnose a patient with Parkinson's disease just because he presented with constipation? No. So that is what I'm saying. Initially, these symptoms like anosmia, constipation, RBD present, but again may not be diagnosed as Parkinson's disease. And remember, these often precede the onset of the classical motor features. So it can be any of the above. any of the above. Okay, moving on to question number 3. Most effective symptomatic treatment for Parkinson's disease. Is it levodopa? Is it dopamine agonist? Is it MAOB inhibitor? Or is it catechol or methyl transferase inhibitor? Tell me in the comment section, what do you think is the answer? Well, all the options which are given, they are drugs which are available in the armamentarium of treatment of Parkinson's disease. So which was the first drug that came? Levodopa. You know, ever since levodopa, we have had many drugs which were discovered for the treatment of patients with Parkinson's disease. But till date, the most effective symptomatic treatment remains levodopa. Levodopa remains the most effective symptomatic treatment. Others are useful, yes, but most effective still remains levodopa. Okay, right. So answer is option A. Let's go to the next question. Question number 4. Among the atypical antipsychotics, the drug with highest propensity to cause drug-induced Parkinsonism is. So all the options which are given, risperidone, olanzapine, quetiapine, clozapine, all of them are atypical antipsychotics. And we know that the antipsychotics can cause drug-induced Parkinsonism because of their dopamine receptor blockade. And the dopamine receptor blockade causing drug-induced Parkinsonism is more with typical antipsychotics, but also can happen with atypical antipsychotics. So this specific MCQ is testing your knowledge on whether you know which atypical antipsychotic blocks the dopamine receptors more and can lead on to drug-induced Parkinsonism. What do you think is the answer for this? Remember, I've taught you in my lectures as well. Among the various atypical antipsychotics, the relative propensity to cause drug-induced Parkinsonism is maximum for risperidone, and almost equivalent you can also have ziprasidone. So risperidone and ziprasidone almost equal propensity to cause drug-induced Parkinsonism. This is followed by olanzapine, quetiapine, and then clozapine. So if the question is highest propensity, it is either risperidone or ziprasidone. And if you look at the options, yes, you have got risperidone in the options. Answer is option A. Got it? Okay, perfect. Let's go to the next question. The next question is the preferred site of DBS, that is deep brain stimulation, in tremor predominant Parkinson's disease is. Okay, so DBS or deep brain stimulation, you know, is the surgical treatment of patients with Parkinson's disease. And for DBS, you actually stimulate certain key regions in the brain, right, to bring about a symptomatic relief. Now they're asking which nucleus is actually stimulated. First of all, you should know that the 3 options that are given, subthalamic nucleus, globus pallidus interna, and ventral intermediate nucleus of thalamus, all these 3 options are stimulation sites for DBS. And in Parkinson's disease, if you ask me overall, what is the most commonly stimulated site, then what is the answer? Suppose if I'm asking you, what is the most commonly stimulated site for DBS in Parkinson's disease, then the answer would have been subthalamic nucleus. But if you look here, the question is about tremor predominant Parkinson's disease. So what is tremor predominant Parkinson's disease? See, when you talk about Parkinson's disease, there are a subset of patients with Parkinson's disease who present mainly with bradykinesia and rigidity. Such sort of Parkinson's disease patient, they are referred to as having hypokinetic rigid Parkinson's disease. Hypokinetic rigid syndrome also, that is sometimes called. That's called hypokinetic rigid PD. These patients also will be having tremor, but the predominant or dominating symptom is bradykinesia and rigidity. So when you see that patient in front of you, Yes, the patient has all sorts of tremor, but what is most striking will be that he is having mask-like face, he is slowness while walking. So that is called a hypokinetic rigid Parkinson's disease. So hypokinetic rigid Parkinson's disease, what is the most commonly preferred site? It is subthalamic nucleus. But there is another subset of patients with Parkinson's disease who may not have very obvious features of bradykinesia rigidity. In fact, their symptoms might be mainly tremor, which is usually an asymmetric tremor. Okay, tremor in one side. Okay, or tremor bilaterally, but again asymmetric, more on one side. So in such sort of tremor predominant Parkinson's disease, well, you will be going for ventral intermediate nucleus of thalamus. My dear students, you should understand that when you go for DBS, okay, see, DBS actually targets certain circuits in the brain. When I've taught you neurology in my lectures, I've told you that in case of Parkinson's disease, the circuit in the brain that is most commonly affected is the motor cortex basal ganglia circuit. That is a circuit that is involving both the motor cortex and the basal ganglia. But remember, in case of tremor in Parkinson's disease, well, hypokinesia, rigidity, all these features, they are attributed to dysfunction involving the circuit. And DBS can target the circuit as well. But the reason for tremor is a different circuit. Okay, so you have got a circuit by name cerebello-thalamo-cortical circuit, cerebello-thalamo-cortical circuit, thalamo-cortical circuit. So in that circuit dysfunction that is again responsible for the tremor in Parkinson's disease, in fact, another disease which is the essential tremor, that is also due to dysfunction of this circuit. So tremor predominant Parkinson's disease, what is the site where you should be stimulating? It's not ST and subthalamic nucleus, it is ventral intermediate nucleus of thalamus. Now let me ask you another question. Please answer in the chat box. Suppose if the question was, what is the preferred site of deep brain stimulation in patients with essential tremor? Remember, essential tremor is a common condition where patients will present with bilateral symmetric tremor. Unlike Parkinson's disease, which is an asymmetrical tremor, essential tremor, which will have a family history as well, patients will be having bilateral symmetric tremor. Remember, here also the stimulus site will be ventral intermediate nucleus of thalamus. Answer would have been option C in that case as well. Okay, right. And when do you prefer globus pallidus internal stimulation? That is when, or the GPI stimulation is often preferred when the patient with Parkinson's disease also has severe dyskinesias. So if the patient with Parkinson's disease is having severe dyskinesias, then the preferred site will be a globus pallidus internal. Okay, right. So I hope I have answered that. And suppose if they're asking another question, which of the following sites can be used for stimulation for DBS in Parkinson's disease, then the answer should be all of the above, because all can be used. Okay, but again in different settings. Okay, subthalamic nucleus mainly for the hypokinetic rigid PD, GPI mainly for the PD with dyskinesias, the ventral intermediate nucleus mainly for the one with tremor predominant. Okay, predominant tremor. Okay, so that is again clear. Now coming to the question number 6, mechanism of action of safinamide. Is it COMT inhibitor, MAOB inhibitor, NMDA receptor antagonist, or is it anticholinergic? See, you have heard about the MAOB inhibitors, right? What are the MAOB inhibitors you know about? Seligelin and rasagelin, correct? Seligelin and rasagelin are the MAOB inhibitors. That is the monoamine oxidase B inhibitors that you know of. And the latest one in the group of MAOB inhibitor is safinamide. Safinamide. So the mechanism of action is option B, MAOB inhibitor. Okay. Now, can I give safinamide to a patient as monotherapy? Like you may get a question which is pharmacology related. Which of the following MAOB inhibitors cannot be used as monotherapy? Is it seligelin, rasagelin, safinamide, all the above? Remember, salicylic and rasagiline can be given as monotherapy as well. But safinamide is often given as an add-on therapy in addition to some other drug like levodopa. Cannot be given as a monotherapy. So for this question, answer is option B. Okay, right. Shall we move on to the next question? Yes. Can we move on to the next question? Yeah. Again, a factual question. The typical frequency of a Parkinsonian tremor. Is it 4 to 5 hertz, 8 to 10 hertz, 12 to 14 hertz, 16 to 18 hertz? Well, this is a simple factual question. The answer is 4 to 5 hertz. In some textbooks, they give it as 4 to 6 hertz as well, which is the typical frequency of the Parkinsonian tremor. And what sort of tremor is seen in Parkinson's disease? It is a rest tremor. It is a tremor which is sometimes pill rolling. Okay, so this is 4 to 5 hertz. Now, let me just tell you, my dear students, when I put questions for the Monday midday exams, you might have noticed that in some exams, I do put very clinical questions. Some exams, a mix of factual and clinical. Some exams, I bring about image-based questions. So basically, I'm trying to train my students for dealing with all sorts of questions. Now, when you look at the entrance exam questions, be it NEET PG or INI-CT, you will also see that in the actual exam as well, there is a mix of questions. You will get factual questions. You will get scenario-based questions. You will get image-based questions. So sometimes when you prepare, what happens is that you may prepare just for clinical scenarios alone or just factual alone. My students have got to have a proper range while preparing so that what sort of question comes in the exam, I want you to be confident in answering that. Okay, that is the purpose of these Monday midday exams as well, where you are given a specific topic and you learn for that topic and then give the exam as well, right? Now coming to the next question, a 57-year-old woman is referred for evaluation of abnormal movements. She was diagnosed with Parkinson's disease 5 years ago by her physician and has been maintained on levodopa for the past 4 years with escalating dose adjustment. Although her Parkinson's disease is under good control, she has recently developed occasional unwanted movement of her arms and legs that have been bothersome to her. She is an accountant and feels that such movements, they are interfering with her relationship with the clients. Which of the following medications should be considered to reduce these movements? Is it amantadine, pramipexole, entacapone, or salicylic? Well, my dear students, see, one thing is quite clear. The patient has been diagnosed with Parkinson's disease. So let us be clear on one fact that, okay, the patient has Parkinson's disease. And the patient has been on treatment with levodopa. Okay, so it has been some time since the patient's Parkinson's disease was diagnosed, and for the past 4 years, the patient is on treatment. And the question says the Parkinson's disease is under good control. So we are assuming that the patient is happy with the medications, but of late, she has developed some problems. And these are certain unwanted movements of her arms and legs, which is bothersome to her. Now, in a patient with long-standing Parkinson's disease on treatment, what do you call such unwanted movements? These can be referred to as dyskinesias. These can be referred to as dyskinesias. So the patient is having some sort of dyskinesias, which are an expected motor fluctuation in patients with Parkinson's disease who are on long-term treatment. And this dyskinesia is interfering with the patient's day-to-day routine as well. Now, what drug can be considered to reduce such sort of dyskinesias? Now, remember, these are sometimes referred to as levodopa-induced dyskinesia. Now, the problem is when you start a patient with levodopa, in the initial phase of treatment, the patient responds very well to levodopa. But after a few years, usually around 5 years after the onset of symptoms, the patient develops a stage where the patient starts developing motor fluctuations. The patients might develop some sort of dyskinesia. Now, what is the problem with this dyskinesia? You might ask me, sir, if the patient develops a drug-induced dyskinesia, don't you think just reducing the dose of levodopa would be sufficient? Because dopamine less is Parkinson's disease. More dopamine is dyskinesia. You reduce the dose of levodopa, can bring the dyskinesia under control. Well, there is a problem with this. In patients who are on such long-term treatment, the moment you start reducing the dose of levodopa, then the patient's features like bradykinesia, rigidity, all those features reappear, including tremor. So there happens this delicate balance, once you slightly reduce fearing this dyskinesia, the bradykinesia, rigidity, tremor comes on. But otherwise, if you keep at that dose, then there is dyskinesia. So how to tackle this? Well, you can consider minor dose reduction of levodopa, yes, possible. But to bring about a control of dyskinesia, there is one drug which is very useful for the control of levodopa-induced dyskinesia. Now, what is that drug? It is amantadine. Remember, option A, amantadine, as an anti-Parkinsonian drug, everyone knows that this is a drug which is beneficial for the treatment of Parkinson's disease. Yes. So it is having anti-Parkinsonian effects, no doubt about it. But in addition to the anti-Parkinsonian effects, it is also having an additional benefit. And what is that additional benefit? It is useful for levodopa-induced dyskinesia. Hence, what is the answer here? Answer is option A, amantadine. Clear with that? Done. Next is question number 9. Not a toxin implicated in secondary Parkinson's disease. So remember, Parkinson's disease can be, usually it is idiopathic, but you can have a condition known as secondary Parkinsonism. So, the correct framing is secondary Parkinsonism. Secondary Parkinsonism means the patient develops Parkinsonian symptoms because of some other reason. Now, I have taught you in my lectures the causes of secondary Parkinsonism. What is the most common? Drug-induced. Example, antipsychotics. It can be due to other causes like tumor, infections, vascular causes, normal pressure hydrocephalus, trauma, liver failure. But very important for both NEET PG and INI-CT, you've got to know about certain toxins that are implicated in the causation of secondary Parkinsonism, which would include carbon monoxide, manganese, MPTP, cyanide, hexane, methanol, and carbon disulfide. These are the toxins that are implicated. So if you look at the options, yes, carbon monoxide, MPTP, carbon disulfide, but it is not magnesium, but instead it is manganese. So answer is option B, magnesium. It is not implicated in secondary Parkinsonism. Coming to the last question of the Monday midday exam, which of the following can be used as rescue therapy during severe off periods? Is it amantadine? Is it apomorphine? Is it levodopa, or is it salicylic? Which of the following? Now, the question is about severe off periods and not just any off period. Well, once the patient develops Parkinson's disease and you give levodopa with combination of carbidopa to the patient, what happens is once the dopamine is replenished, the patient develops, patient has an improvement. Now, when there is adequate dopamine levels in your brain, that is when you say that the patient is in an on state, okay. But as the disease progresses, what happens is the levodopa may not give you the desired benefit. For example, if you say that, if I say patient was taking levodopa, one tablet at 7 a.m. in the morning, next tablet at 11 a.m. and next tablet at 3 p.m. So essentially the duration of action of the drug was there for at least 4 hours. So the patient would say that from 7 a.m. once he starts taking the tablet to 11 a.m., he's fine, he's doing well, he's in on time. But what happens is as the disease duration progresses, the on time reduces and off time increases. So patient might say that, doctor, from 7 a.m. to around 9 o'clock, I am doing good. But after that, again, it seems that the drug benefit is relatively lost. So that's called off period when you do not have adequate dopamine levels. Now, if the patient has some off period, what is that you can do? You can try to prolong the action of levodopa. And how do you do that? You can give drugs like MAOB inhibitors or catechol or methyl transferase inhibitors. You can give such sort of drugs which can prolong the action of levodopa. But when you have got a severe off period, which means, the patient would be literally freezing. There will be freezing of gait. Okay, freezing of gait. Okay, so when there is such sort of freezing of gait, you will have to give some drug as the rescue therapy. And what is that drug as the rescue therapy? It is apomorphine, which is a dopamine agonist. So apomorphine is a dopamine agonist, okay, which is used as a rescue therapy. Okay, it is a dopamine agonist that is used as a rescue therapy. Rescue means what? You're trying to save. And when do you need somebody to save you? When you are in deep trouble. Okay, so severe off periods, you can go for apomorphine. Okay, right. So that is what you can do. Okay, can't you give levodopa? See, what is the problem here? You're giving levodopa, which is not getting you the desired benefit. So there is no point giving levodopa again. So severe off periods, you should be thinking of drugs like apomorphine. So these are the questions of the Monday midday exam series. So keep following the Monday midday exam series. Wait for the next topics, prepare accordingly. I'm sure that such sort of exams, they are actually going to give you a lot of benefit because again, this is a focused learning, right? You are learning a topic specifically and you are going and writing an exam. So which means you will be very thorough with that topic. So keep learning. I hope you were happy with the questions as well. Keep following for more such exams as well. And for more updates, you can follow my Instagram page as well, dr_Rahul_Rajeev. This is my Instagram ID. You can follow the Instagram page for many such academic updates as well. So thank you so much, everyone, for joining, and keep waiting for the next exam in the Monday.